now we're moving on to the stepped wedge design, and Patty Chondros will be our second speaker.
Okay. Good afternoon, everyone. Today I'm going to talk about the Stepped-wedge cluster randomized trials in terms of registry-based data sets. In particular, I'm going to present some of the design aspects of the Stepped-wedge design in the context of primary care research, as cluster randomized trials are commonly used in this area. But first, I'll illustrate how registry-based data in primary care can be used, and then I'll describe the Stepped-wedge cluster randomized trials using the core study as an example. So, oops. Okay. So, with registry data in primary care, there are several large general practice data sets that are currently held in various places. So, I've got the NPS Medicine Insight data set. A number of primary healthcare networks also hold large general practice data sets, as well as several departments of general practice. And these are usually data sets that are drawn from general practices' electronic medical records. So there's also lots of opportunities to also link this data with other hospital data and registries, and therefore you can follow the patient's health journey throughout the whole health system. Currently, there's also under development data asset looking at having primary healthcare data. The next slide presents an example of how the GP electronic medical data can be linked with other sources. So we had three registries. One was the general practice EMR. So that was so we selected individuals who attended general practice in 2013. And that was linked with the Australian Orthopaedic Association National Joint Replacement Registry data that contains all total knee reconstructions in Australia since 2000. And as well as that, we also included the National Death Index. So in the end, there was a completed data set with GP patients who underwent total knee replacement in the study period. And this allowed us to address the aim of understanding the management of osteoarthritis in general practice. And this has already been these data have already currently been linked as part of a PhD project being conducted at St. Vincent's Hospital. Okay. So just a moment over. So I'm just going to read off the slides. There were a couple of slides leading into this. So Andrew actually covered a lot about cluster randomized trials. And as he said, cluster randomized trials randomize individuals to the intervention and control arms, whilst the outcomes are measured at the individual level. And often examples of this might be general practice, school, or communities. They're commonly used in primary care research because the interventions are often targeted at the general practice level. And one of the reasons why they might do that is to avoid contamination, where individuals in the cluster, in the control cluster, may be exposed to intervention partially or completely. So some examples of interventions in primary care might be implementing guidelines, GP training, or system changes. So how does the Stepped-wedge design relate to a cluster randomized trial? So it's a special type of cluster randomized trial with a crossover design in only one direction. So often other terms used to describe this kind of study are phased and standard implementation, multiple baseline, or dynamic waitlisted trials. And we've seen in the literature that they're increasingly being used, and they to evaluate health policy and service research, data-driven quality improvement programs, as well as implementation studies or pragmatic trials where we look at pragmatic or effectiveness trials or complex interventions. So here's an example of a cluster randomized step-wedge trial in primary care that actually uses GP electronic medical records. So the aim was to evaluate a data-driven quality improvement intervention in primary care. And they used 40 volunteer general practices in 2 Scottish health boards, and they randomized them using a step-wedge design of 10 steps. And the outcome measure was, so the target was to reduce high-risk prescribing. So the outcome measure was medication use, and that was automatically extracted from GP electronic medical records. So that just illustrates an example of using registry-based data in primary care. So here I've got a schematic of a step-wedge cluster randomized trial. And this has been replicated from a paper published by Barker in 2016. Here you see that you've got 10 clusters randomized in 5 steps in groups of 2. In groups of 2 over a period of time. So the key characteristics of a step-wedge cluster randomized trials is that all clusters start in the control phase. And then the randomization then determines the order in which the intervention is implemented. So here you've got the sequences, 1, 2, 3, 4, 5, and then the first lot that get randomized switch over to the intervention phase. The clusters or groups of clusters, so it might be one cluster or several clusters grouped together, are randomly assigned to a time point where they then switch over or cross over from the control intervention phase into the control phase into the intervention phase. Now, all the clusters are also followed longitudinally, and the outcomes at endpoints are then usually measured at discrete time points at each period of time. So here I use the example of the so I apologize, some of my slides are missing, so I'm just going to talk to them. So here is the example of the core study that I will use to illustrate the use of step-wedge designs and some of the issues that might arise. So the aim of the core study was to test the effectiveness of an experience-based co-design intervention, which was a very complex intervention and involved lots of staff and service users and carers participating in a facilitated process to collaboratively co-design improvements for better service experiences. And the goal was to improve the services so you can optimize recovery orientation with services. So the population were people with serious mental illnesses who attend these health services in Victoria, and the primary outcome was psychosocial recovery, which was measured on the individual levels through CADIs, which were computer-assisted telephone interviews. So when using a step-wedge design, there needs to be a good rationale for using such a design. So the rationale for the core study was that we were limited by the number of health services available, so we only had 9. Okay. So a parallel cluster randomized trial was not feasible in this instance. The intervention itself was complex at the organisational and service level, and it was quite intensive, so it couldn't be delivered concurrently to all clusters. Also, it was considered to be a vulnerable population, so some considered it not ethical to withhold intervention perceived to be beneficial. As well as that the step-wedge design was preferable to pre-post design where there's no randomization element or even no evaluation at all. And it was funders also suggested that it was a good design to use in this context. So here we've got the schematic. Sorry, I can't hear. So here I've got the schematic of the core study showing that the 3 clusters were randomized at each arm. The arm indicates the allocation or group of clusters at each of the individuals. So there's 4 time points and the length of each step. So you also need to decide on how long the individual lengths are going to be. Was 9 months. So to have all these 4 time points, we needed 4 years to complete the study. Now, once they get randomized into the intervention phase, which is the grey zone here, a lot of the clusters, depending on when they get randomized, the exposure to the intervention of the clusters will depend on how, on the length of time. So the exposure time, it depends on when they were randomized into the intervention phase. So they've got varying times at which clusters are exposed to intervention. So also notice here I use the word phases and intervention phase and control phase rather than arms, because it's we compare the clusters in the control phase to the clusters in the intervention phases. So here I've just copied the schedule of enrolment and assessments that was published in the protocol, just to illustrate the number of different data collection points required with a step-wedge design, where we've got 4 data measurement time points. There was also a collection on service users, carers and staff. But at the same time, we also collected information on health services use for the economics analysis. And this was extracted from other external data sets such as the Medicare, the MBS data and the PBS data and hospital data. The one difficulty of this trial was that, as well as consenting the patients into the trial themselves, we also needed to get separate consent to then collect the data from the external data sources.
Sorry, Patty, I'm just going to change over to present, and that way we'll have your full presentation ready. So just bear with me for a moment.
Okay.
There you go, and you will have keyboard and mouse control.
Okay, thank you.
Right now. Apologies for that.
Okay, so some of the other design features of step-wedge cluster randomized trials, which aren't just specifically unique to stepped-wedge design, it's the case for cluster randomized trials as well, is the different kinds of sampling of the individuals. So we can have cross-sectional data where we have independent samples at each time point, and then different individuals are measured at each one of those time points. The other types are the cohort designs, where you can have a closed cohort or longitudinal data where the individuals are all recruited at the beginning of the study, and then we have repeated measures on the same individual at each time point. But no new individuals can join after the study starts. However, with the open cohort, it's a variation on the closed cohort study, where we still have individuals with repeated measures over time, but new individuals can join over the study duration. Okay. So I'm going to quickly go through the next few slides. These slides just go through the different reasoning of why we ended up using an open cohort sample for the core study. And one of it was because it was an extremely difficult population to reach. The sample cluster sizes of the health services range from 60 to 350 clients. So if we went with a repeated cross-sectional, then there's a higher chance of sampling the same individuals over time, plus the increased chance of selection bias. Also, it was quite expensive to recruit the individuals, so it was easy to recruit them all at the beginning of the study. The open cohort we use because over the length of the study, because of the length of the study over 4 years, we would expect that clients may leave the health services and new clients may register. So it was important to capture the variation as it goes as they move through the study. So by using the open cohort design, we did manage to minimize selection bias so that where the participants were recruited prior to randomization. However, each step was quite long, of 9 months. So some clusters wait a long time before starting the intervention. So the motivation to participate in the study may decrease both with the clusters and the individuals. So there might be a greater attrition rate over time. The other is that participants may not attend the health service over that health service after the intervention was implemented. So there's a risk that the individuals are not exposed to the intervention. Plus, they also took us much longer to recruit the participants at the beginning of the study, and that extended the length of the study. Now, some of these challenges can be overcome by using routinely collected data. So a quick overview of all the considerations you need for a Stepped-wedge cluster randomized trial. The ones highlighted in blue are specific for the Stepped-wedge cluster randomized trial, whereas all of the other considerations like the number of clusters, the number of individuals per cluster, and whether it's a cross-sectional cohort design is for any cluster randomized trial. And in thinking about all these aspects, we also need to think about the logistical and practical considerations. So do we have enough clusters? Are we going to be able to identify enough participants? Can we randomize all of the clusters at the same time point? If you use a Stepped-wedge design, this can extend the study duration, as well as the feasibility and costs or the resources you need to conduct the study. So I've just replicated one of the slides that Andrew used in his earlier presentation, where we present the parallel cluster randomized trial where all the clusters are either in the intervention arm or the control arm, whereas a Stepped-wedge design, clusters can also contribute to the control conditions as well as the intervention conditions. And there's no switchback, unlike the crossover trial presented earlier. With these kind of interventions, when they're complex, it's very difficult to withdraw, so you can't go back and forth, so you can only go in one direction. So I'm just going to take a step back and just present again about the sample size calculations for cluster randomized trial as compared to the individual randomized trial, and Andrew covered a lot of those aspects. And so one of the characteristics of a cluster randomized trial is that the individuals that attend the same health service will be more alike on their outcomes. So this means that we'll have some within cluster and between cluster variance. And this is often quantified by the intra-cluster correlation, or if we're looking at GPs, the intra-practice correlation, within practice correlation. And the effect of that is there's loss of information. So potentially, if we don't allow for this in our design or analysis, then the effective, it's important to allow for this in the sample size in the analysis. And the effects of clustering is that as the ICC or intra-cluster correlation increases or the cluster size increases, compared to the randomized control trial, the study efficiency or power will be less. So before I go into, so given that our parameters were that we were looking for an effect size of 0.35 of a standard deviation, and we assumed an intra-cluster correlation of 0.1. And we were limited by our cluster sizes because it was a hard to reach population, and also it was very costly to recruit them. So our cluster sizes themselves were quite small, and the number of clusters we had to randomize were 9. So all up, we would have 270 participants from 9 clusters. When you do the sample size calculations, to conduct this as a parallel cluster randomized trial, our power would be very low. And to be able to achieve 80% power, assuming everything else is held constant, we would actually need 34 clusters and a total of over 1,000 participants, which is actually not practical in this setting. So So we use the sample size for the step-wedge cluster randomized. So typically a step-wedge cluster randomized trial would require fewer clusters than the standard parallel cluster randomized trial. But that also depends on the inter-cluster correlation, the size of the cluster, as well as how many periods you're collecting measurements on over time. And the sample size calculations, and here I assume cross-sectional samples because it simplifies for cross-sectional sample, is that both within cluster and between cluster variant, we use both within cluster and between cluster variants to estimate the intervention effect. And generally, it's relatively insensitive, the sample size calculations, to the correlation of individuals belonging to the same cluster. Most of the gains are from the measurements, over repeated measurements over time, so having lots of measurement time points, as well as the correlation across the clusters within time periods. And if you have got a fixed number of clusters, then you can also increase the study power by increasing the number of measurements over time. The general sample size calculations also assume that we're getting the full effect of the intervention occurs at the same time intervals when the intervention is introduced. However, there can always be delay in the intervention effect, and it reduces the study power. And the way in which we can overcome that again is introduce more measurement periods. So here I'll just briefly show you the core study. Because we used an open cohort, there weren't that many formulas for sample size calculations, so we used a simulation study to then conduct power calculations. So this table is copied from the protocol paper, and again, using the same conditions as before, with an effect size, detected an effect size of 0.35 of 1 standard deviation, given the same restrictions where we've only got 30 individuals per cluster and 9 clusters. We were able to demonstrate that with repeated measures, assuming we have cross-sectional samples, we had at least 80% power. By allowing for repeated measures on the same individual over time, we can also demonstrate we can increase the study power. So with regards to analytical methods for step-wedge cluster randomized trials, there's a lot of different methods being published in the papers that are of the published step-wedge cluster randomized trials. There's currently no consensus. There's still an active area of methodological research. So it's suggested that whichever approach you use, that you pre-specify the analytical approach, and a commonly used approach is the mixed effects regression. They can account for all the different correlation structures. If anything, the analysis should allow for the correlation structures that's in your created by design. As well, what is very important, both in the analysis and sample size, you also need to allow for confounding by time. So the study is time variant. So any changes in intervention effect may also be due to changes in time. For instance, patients may recover or deteriorate with time regardless of the intervention phase. So some of the challenges with the step-wedge cluster randomized trial, it often may require a longer trial duration, especially with complex interventions where it can take a long time to implement. And also they're best when the outcome can be measured immediately after the intervention. So if it takes a while for it to be embedded, then this could also extend the study duration, making the step-wedge design impractical. One of the other issues is that you do have multiple data collection time points, and if you're collecting it directly from the individuals or the participants, then it can actually be a burden both on the participants, especially if they're contributing to more than one time point, but also in trying to identify the cross-sectional participants over time. So in this instance, this is where routinely collected data can contribute to the data collection. There's also other risks of bias and contamination, such that intervention participants and those waiting for the, such as the risk of contamination between intervention participants and those waiting for the intervention. And the other challenge is that all classes need to be recruited prior to randomization. However, this is not the case for cluster randomized trials in general. So just to summarise, there's there's debate around the level of evidence provided by the step-wedge cluster randomised trials. So when you do choose it, it needs good rationale for its use. Where possible, we choose a parallel cluster randomised trial over step-wedge cluster randomised trials for the reasons presented on this slide. The registry-based trials may help mitigate the risk of bias and data collection burden, but then has other challenges such as the data quality and other challenges presented earlier by Andrew. So thank you.
Thank you very much.